A patient presents to the clinic with harsh, noisy nighttime breathing. Because the patient is usually unaware of the sound, the clinical investigation begins only when an alarmed bed partner reports the issue. The common clinical reflex identifies this noise as benign primary snoring or obstructive sleep apnea. However, the frequency of the sound suggests a different pathology. This noise is high-pitched, harsh, and described as a continuous gasping or crowing. This is sleep-related stridor. Unlike the low-frequency vibration of snoring, this high-pitched sound occurs primarily during the inspiratory phase of the breathing cycle. This acoustic profile points to an upper airway obstruction at the level of the larynx, specifically the vocal cords. Sleep-related stridor serves as a clinical indicator of serious underlying neurological disease. Misclassifying a high-pitched laryngeal obstruction as low-frequency palatal snoring obscures the early signs of a fatal neurodegenerative decline. Primary snoring originates in the upper throat, caused by the passive vibration of the soft palate. Stridor originates much lower, mapping directly to the vocal cords. During sleep, they fail to stay open, severely restricting the glottic opening during inspiration. This localized narrowing forces inhaled air through a tiny passage, spiking resistance. As air accelerates, it loses its smooth flow, becoming chaotic, a state known as turbulent airflow. This physical turbulence creates the harsh, high-frequency acoustic output clinicians hear as stridor. The sound is a direct physical translation of extreme air velocity forced through a malfunctioning biological valve. Identifying why that valve malfunctions requires moving beyond fluid physics and into the neural mechanisms controlling the laryngeal muscles. Unlike the passive tissue collapse of a snore, stridor stems from active dysfunction in the motor control of the larynx. This failure presents mechanically as vocal cord paralysis, paradoxical motion, or reduced abduction, an inability of the cords to pull apart during inspiration. This specific dysfunction carries a high-yield clinical association with multiple system atrophy, or MSA. MSA is a progressive disease that targets and degrades structures in the brainstem and the autonomic nervous system. As it progresses, the brainstem loses its ability to send proper motor control signals to the laryngeal muscles. Without these signals, the vocal cords cannot open properly when the patient enters sleep states. Make no mistake, stridor is a critical alarm bell for severe central nervous system degeneration manifesting in the airway. Clinical observation alone is insufficient to confirm this. Clinicians must rely on objective data from a polysomnography study. This chart shows obstructive sleep apnea, with flat lines in airflow and rhythmic drops in oxygen. A second chart showing stridor completely lacks these classic apneic pauses and oxygen desaturation events. Instead, the marker of stridor is inspiratory flow limitation, seen as flattened, squared-off peaks in the airflow curve. An integrated audio recording captures high-pitch acoustic frequencies, synchronizing perfectly with these flattened curves. Direct laryngoscopy then allows for visual confirmation of the vocal cord dysfunction indicated by the sleep study data. Synchronizing inspiratory flow limitation with high-frequency audio provides the objective evidence needed to rule out standard sleep apnea. Following a diagnosis, the immediate priority is physically securing the compromised laryngeal airway. Continuous positive airway pressure acts as a pneumatic splint. The pressurized air physically forces the narrowed vocal cords apart. Holding the glottis open with pressure reduces airway resistance and restores smooth, laminar airflow. In severe cases where non-invasive splinting fails, a tracheostomy is required to bypass the larynx and prevent sudden respiratory failure. These mechanical interventions prevent airway collapse, even as the underlying neurological condition continues to progress. While the airway can be managed, the reality of the underlying neurological etiology remains. Because sleep-related stridor is heavily linked to multiple system atrophy, the long-term prognosis is progressive and serious. In patients with MSA, the presence of stridor is specifically associated with a statistically significant increase in mortality risk. Disregarding this sound as mere noisy breathing risks missing the window to prevent sudden respiratory compromise. Not all noisy nighttime breathing is benign. Recognizing the acoustic and physiological markers of sleep-related stridor provides the evidence necessary to detect a life-threatening pathology.